with cancer care, most patients expect that there are going to be side effects, and sort of working with them and the oncologist in terms of how far do we need to get in terms of where they're comfortable. And for each patient, I've learned that that can be quite different. I have a patient who has intermittent itching, and it's not particularly significant, but that was enough for him to go off his immunotherapy.
On this episode of Cancer Buzz, the role of dermatology in immunotherapy treatment, and how cancer programs can better integrate dermatologists into the care team. What you need to know is next. Welcome to Cancer Buzz. I'm your host, Summer Johnson. In a survey of nearly 400 cancer survivors, more than 2/3 felt that the skin toxicities they experienced from treatment were worse than what they had expected, and 84% were not referred to a dermatologist. For patients going through treatment with immunotherapy, immune-related adverse events most often present on the skin and can be so severe that patients opt to stop their treatment. These dermatologic side effects can take a huge toll on patients, impacting their physical and emotional well-being. We set out to learn what cancer programs are doing to help patients manage these side effects, and found that some programs are integrating dermatology into their care teams. Cancer Buzz spoke with Dr. Joshua Arbesman, a dermatologist specializing in Oncodermatology at the Cleveland Clinic.
Initially, we were mostly sort of incorporated within the melanoma oncology sphere, where we would care for patients, particularly with melanoma and also cutaneous squamous cell carcinoma, in concert with oncologists. I think there was some degree of overlap when traditional chemotherapeutic agents had skin side effects. I think that was less. As time has gone on, though, the whole field of oncodermatology, where we care for individuals with skin side effects to cancer-related care, in particular to immunotherapy, I think has increased significantly. And I've definitely seen, I started training during the time period where a lot of these drugs were being approved. And I definitely see the integration increasing over time, even within the last few years, where there's a lot of communication between me and other oncologists about cancer-related care for patients.
Talk about your role in caring for patients as part of the greater cancer care team.
Sure. So I think of my role in two ways. One is specifically relationship with melanoma patients and coordination with long-term care of melanoma patients. And that interplays with melanoma oncologists, screening those patients for recurrence of their cancer, but also in terms of getting new cancers as well on their skin. So that's one aspect of my role. The second aspect of my role is interfacing with oncologists when the patients have skin side effects to their cancer treatment, and coordinating with them, whether it be appointments on the same day, and also discussing with them how to manage those skin side effects and allowing the patients to stay on their cancer-related care if possible, and talking with them about that and coordinating care in that regard and managing those skin side effects.
What does that referral pathway look like? Do patients present to you after they have a problem, or are you brought in with immunotherapy patients from the beginning?
So I think with melanoma patients, we're sort of brought in at the beginning. There is sort of this reflexive situation within the melanoma world at the Cleveland Clinic where patients are often told you should see the dermatologist at least every 3 months because of side effects, but also because that's sort of their standard screening frequency that they would be required. When it comes to other oncologists, whether it be patients with lung cancer or kidney cancer or any other cancers, then it's more on an as-needed basis, where oftentimes I'm contacted by the oncologist saying, this is what's going on, can we have them see you? And I often am able to see them soon, and or we talk about, is there something that we can do in the interim until I'm able to see that patient in person? And sort of, we're talking about creating an algorithmic approach for some of these patients where if they have this amount of their skin involved, we start with X treatment, and if it's this particular type of rash. So we're trying to figure out a way that we can streamline it such that we can get the patients in, but also if they're not able to get in, we can manage them earlier on.
What do you like to know when these immunotherapy patients are referred to you?
Yeah, so I think most importantly is sort of what are the current goals of therapy that the patient has, and what was the initial plan for the therapy. And what I mean by that is both in terms of, are they getting treatment immunotherapy that we need to keep them on this therapy as long as possible because they have active cancer disease, Or is it an adjuvant setting where we're trying to prevent recurrence, but sometimes we go off that therapy more quickly if they have side effects? So that's one thing that's critical because it may define in terms of how rapidly we may have to move, but also how aggressive we may have to move in terms of the treatment of their skin. The other thing is whether they've been on therapy for a lot longer and maybe the plan was to come off in the near future anyways and sort of what that means. And obviously, there's time before the skin side effects will decrease once they've gone off immunotherapy. But if the plan is for them to go back on, then I really need to know how quickly I need to get their skin under control. There's a patient that I am currently seeing who had to go off her therapy. And the goal is we want to see what her scans show in the near future, but she potentially wants to go back onto therapy. And so we're trying to work to get her skin under control as soon as possible. She has significant psoriasis on her skin, and we want to figure out ways that we can get her skin under control, but not affect the efficacy of her immunotherapy that she already has received. So those are the major things that I like to think about when I'm planning for their care.
What are you looking for in signs and symptoms that would help you differentiate an immune adverse related event versus another dermatological event?
I think timing is critical, although we found over time that we will see immune-related adverse events that occur early in therapy, later in therapy, after therapy has stopped. We sometimes even see immune-related adverse events where it's a pretty significant condition. I can think of a patient who was a number of months off therapy and then only at that point in time developed bullous pemphigoid on their skin. She had received also an experimental therapy that was immune-related, and she had significant long-term effects. And that was actually a situation we were trying to decide, is this truly related to the immunotherapy, or is this sort of an unmasking of something that was already going to come to play? I think a lot of skin rashes will be driven by immunotherapy. And oftentimes I think of them as almost psoriasis-like, eczema-like. They're not exactly the same in terms of how they present, in terms of how they respond to therapy. But I think most of the time, if the timing is right, we assume that they're interconnected with immunotherapy because that's the most logical explanation, at least at that point in time.
What have you learned that stands out to you about patients in IO treatment?
So I would say there's two things that I've learned over time. One is trying to figure out with the patient sort of what are their goals with their skin and how far do they feel they need to get in terms of getting them comfortable, but not necessarily cured on terms of their skin so that they can continue on their cancer-related care. The most critical thing is with a standard rash, we try to make someone's skin clear as much as possible. With cancer care, most patients expect that there are going to be side effects, and sort of working with them and the oncologist in terms of how far do we need to get in terms of where they're comfortable. And for each patient, I've learned that that can be quite different. I have a patient who has intermittent itching, and it's not particularly significant, but that was enough for him to go off his immunotherapy. Versus another patient will have psoriasis over a large portion of their body, and they're like, I still want to get my immunotherapy. And it's working with a patient and understanding and talking with oncologists where they need to go. So that's point one that I've learned. The second point that I found is that some patients' skin reactions can move more slowly and some can move quite rapidly. And learning to educate the patient that if your skin rash moves more quickly, please let me know because we may change the therapeutic options that we've talked about so that they're aware what are the warning signs to look for and other things that can occur on their skin that it's if they get blisters, something of that nature would make us move more quickly in terms of the treatment and more aggressively.
Are there any commonalities in patients you've found that if their skin heals more quickly or advances more slowly, for example, is age a factor?
I think sometimes I've definitely noticed actually certain patients with particular types of cancers may have more of a significant response on their skin. I know there's data that's emerging on that. I definitely have a lot of patients with lung cancer who have pretty significant skin reactions. That's something that I've noticed. I'd have to go back and look at the most recent papers to see if that's been reported as data-driven as I'm seeing anecdotally. But I would say the majority of the patients that have had the most robust skin reactions have been lung cancer patients for whatever reason. And that is something that I think we need to think about because preparing patients appropriately in that regard, depending on the cancer that they're having treated may be important.
Let's switch now and talk about the Cleveland Clinic's tumor board. Can you walk us through how that group works and how you fit in and how you all work together for patients?
Sure. It's a multidisciplinary group of individuals. We meet twice a month, although I think we're going to increase the frequency because we have more and more cases. It's a case-based presentation situation where we have specialists, obviously from oncology, but also from nephrology, dermatology, rheumatology, and a whole host of other fields that I'm not remembering, including neurology and cardiology, and I'll keep on listing. Basically, every specialty is potentially represented because the immunotherapy affects basically the entire body. And what the idea is, we have these case-based presentations for more challenging situations where we want to think about what is the best next step, whether it be because the patient has had significant side effects from their immunotherapy, but their cancer is advancing, and what is the best way to help manage in that situation? Or it may be a situation where the immunotherapy is affecting multiple organ systems and trying to coordinate care amongst multiple specialties. And or we're at a loss where the patient is not responding to the therapies that we've used to manage their IRE, but maybe we can get insight from other specialties that may have had success with X, Y, or Z therapy that didn't necessarily affect the cancer care. And where I come in is I help with regards to the dermatologic side effects and providing insight from my experience that I've seen with patients and working with others when they may have skin side effects plus other side effects and helping to coordinate care in that regard.
So your program is pretty unique, right? You have Oncodermatology sitting in with the multidisciplinary team. Talk to your colleagues across the nation who don't have that. How can oncology teams better connect with dermatologists and better communicate with dermatologists, particularly about IO patients?
Yeah, so I think oncodermatology is an emerging field, and I think there's a lot of dermatologists that are actually getting quite interested in that area and finding comfort in managing those patients. And so I think the major thing that the oncologists and dermatologists can do is just have that touch point where they find someone that's obviously interested in oncodermatology and connecting with that individual and having those lines of communication open. I think for me is helpful is that we talk regularly, whether it be the advanced practice providers or the oncologists themselves, and coordinating when the patient is not able to see me in person, how I can help with that regard. But I think just having that person that's a touch point is critical. And I think there are a lot of people that are starting to be much more interested in that realm. And it's definitely becoming part of dermatology training where I train residents and help them understand what they would need to do in these particular situations.
Check out the show notes for resources related to today's show. Thank you for supporting Cancer Buzz. If you enjoyed this episode, there are 3 ways you can help us continue to make the show. Please give us a rating and a review on Apple Podcasts and share the episode with a colleague. Next time on Cancer Buzz, we examine the gender gap in cancer program leadership and how one program is reaching out to young women through a unique mentoring experience. Until then, for the entire Cancer Buzz team, I'm Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.